Here we present our technique for an anterior cruciate ligament repair with internal bracing. Our author's conflicts of interest are available at aaos.org/disclosure. Our patient presents after a pop in their knee while doing jumping jacks. They report a 5-month history of constant soreness with associated swelling and buckling. After failed conservative management, they came across to our practice seeking additional treatment options. The patient demonstrates a normal range of motion with intact strength on flexion and extension. They are tender over the posterior fossa and have a positive anterior drawer and unstable lockment and pivot shift. Weight-bearing x-rays showed no signs of arthritis, malalignment, or major pathology. Sagittal and coronal MRIs demonstrate an elongated and avulsed ACL from its femoral attachment without any rupture sign. No concomitant cartilage or meniscal injury was seen in the MRI examination. As such, we conclude a diagnosis of a deficient ACL and proceed with a repair. We begin by viewing the ACL from the anterior lateral portal on the right side of the knee. Notchplasty was then performed using a bone cutter. Ligament integrity was sufficient. However, the femoral attachment, particularly on the anterior medial band, was found to be insufficient and avulsed from the femoral side. Microfracture of the footprint was performed in order to ensure the migration of stem cells, which are thought to contribute to healing. Then, ACL suture passing was done through the posterior lateral portal using Smith & Nephew's First Pass ST self-retrieving suture passer and Arthrex suture tape and No. 2 fiber wire. Sutures are passed through both the anterior medial bundle and posterior lateral bundle from the intact distal end towards the avulsed proximal end in an interlocking pattern. Three to 4 passes through a passport button cannula in the anterior medial portal can usually be made before the final pass exits the proximal end towards the femur. Next, tension of the ACL and the footprint is checked by pulling the threads with the suture retriever. Tape sutures are then retrieved through the accessory portal. Similarly, the suturing of the posterior lateral bundle is performed using a suture passer and No. 2 fiber wire in the same fashion. Sutures are retrieved through the accessory portals accordingly. With the knee at 90 degrees flexion, a 4.5 20mm hole is punched and taped into the origin of the anterior medial bundle within the femoral footprint. The suture threads are loaded to a 4.75mm vented biocomposite swivel lock suture anchor that is preloaded with fiber tape and placed to the already prepared footprint. After the proximal footprint fixation, an ACL guide is then used to drill a 2.4mm drill pin up through the tibia from the anterior medial cortex and into the anterior half of the ACL tibial insertion. A suture lasso is placed through this drill hole. Preloaded fiber tape threads are then passed through the suture lasso and shuttled along the ACL substance, down through the tibia. This is fixated with the suture anchor perpendicular to the tibial cortex. Final view of the repaired ACL and examination of its tension with an arthroscopic probe is seen from the anterior lateral and anterior medial portals, respectively. Postoperative rehabilitation consists of a non-weight-bearing status until 6 weeks postoperatively. The patient will undergo physical examination to regain their strength and range of motion is tolerated. One study reporting the outcomes of internal bracing on 56 patients showed improved subjective outcomes after repair with the internal brace as compared to those without, demonstrating the potential role of additional bracing on bettering patient outcomes. Thank you for watching our demonstration of an ACL repair with internal bracing.